Hello and welcome to the IdeaCast interview series, episode 27. My guest today is Dr. Serife Tekin, and she is the Associate Professor of Philosophy at the University of Texas at San Antonio at the Department of Philosophy and Classics. She is also the current recipient of the UTSA's Lutcher Brown Fellowship, and she's also the director of the Medical Humanities program at UTSA. And she is currently, as of the time of this recording, a visiting fellow at the Center for Philosophy and Science at the University of Pittsburgh. And in this conversation, I speak with Dr. Tekin about a project that she's undertaken, and it relates to the DSM, and we will uncover that and talk about it in this conversation. We also talk about concepts of the self, and she has a model that she's put together of the self that has a great utility or potential utility if it's implemented for people to work with. So it's a great conversation. It's of course my opinion, but I think it was a wonderful conversation, and I hope you would enjoy it as well. And thank you for joining us. And I would like to welcome Dr. Tekin to the IdeaCast interview series. I'm so glad to have her on board today, and welcome to you. It's good to see you.
Thank you, Justin. Thank you for hosting me.
Absolutely, absolutely. I've been kind of casually following you on Twitter, and then I dug a little deeper into your work, and I thought, oh my gosh, this is really interesting because I think what you're doing is important and also meaningful in a very, if you want to broaden the sense of meaning out, it's meaningful to others, it's meaningful to the work, to the discipline, to the sciences that are involved. And so it's something I think is certainly worth talking about. And if this little video or little conversation can make its way out into the world and influence people or give people an impression or shed light on things that are going on, I think that's great. So let me ask you, if you would, to give us an introduction to the project, that the research that you've been doing and the project you've been working on, and get us started that way.
That's great. Yeah, thank you, Justin. I think one of the biggest compliments that I have received in my work is this very kind of point that it is relevant, it is important, it is meaningful. I think my motto has always been to be a philosopher or to do philosophy that matters. So I'm really, really happy to that it's being perceived that way, in the kind of bigger world out there. So I have several connected research projects, as you can imagine, but the central goal, the central aim is to make the concept of the self central to our understanding and representation of mental disorders. This applies to kind of a person's own understanding of their encounter with mental disorder in relation to who they are. But it also relates to making kind of the science of mental disorder, or I should say maybe collective sciences of mental disorders, to be more interested in the concept of the self in making sense of defining, diagnosing, and treating mental disorders. And a lot of when I kind of look at the contemporary scene in mental health treatment, clinical treatment of individuals with mental disorders, I see that there's not enough emphasis on concepts like the self or person or kind of good life, meaningful life, or well-being. And in a lot of ways, I'm kind of trying to bring this work on the self in philosophy and in cognitive sciences and psychology, in the sciences of the mind overall, to bear on these essential questions about what does it mean to be depressed, or how do we help the person with depression, and so on and so forth. And in a lot of ways, kind of I have like the horizon that I'm looking at is the ethics of treating individuals who struggle with mental disorders and might need help. Sometimes that might mean not labeling them as mentally ill, but I'm sure we will get to that point at some point in the conversation. So that's broadly my research.
Okay. And for anyone who hasn't seen any of my other interviews before, I am sort of the pop science, the general audience kind of. I'm a lay person. And so just reading through your work, I watched several of your videos where you gave lectures and talked to different crowds at different schools and universities. And my takeaway, and again, it's through naivety and some ignorance here that I'm saying this, but I'll put this out and then you can work with it. And that's that I see that there's research psychiatry and there's clinical psychiatry, and the research has to be grounded in science to a degree, but there's a cost benefit to that there is, and dehumanizing might be too strong of or even polemic a term, but that they have to be in this mode of science and reason and so forth, but nonetheless, there are things left out of that. And so perhaps that the clinical side of psychiatry has a little more space to do the human interaction and take interest in or invest in the narrative of the person who is presenting X to them, the situation. But yes, to get back to the research end of it, and you mentioned cognitive science, and I think one thing cognitive science strives to do is understand, like you said, a more global perspective of what this is. You know, there's obviously this corporeal thing, this Justin or Dr. Tekin, and you know what are the layers underneath. And so it's interesting that again listening to your lectures, that there is this kind of vacuum there when it comes to including the information of whether it's anecdote or and I'll save a question, I guess, like having people within the system report who can be sort of expert witnesses to the event. So people in psychiatry, psychology, who are dealing with perhaps either subclinical issues or pathologies. So I know I'm on a ramble, but I guess to get to a point, excuse me, there seems to be something missing, and that's what you're addressing. And so, and that involves generations of the DSM, slowly, it sounds like it's slowly, glacially creeping its way. I think you had mentioned there's axial things going on now, like they're incorporating different perspectival means of otherwise sterile information. So could you speak to the DSM and what's been going on in this, again, this somewhat slow process?
Absolutely. So I think I want to kind of start with like your earlier points in this question about like the science, scientific goals of psychiatry. So when we think about science, kind of the generic the generic knowledge that we have about science, well, science is objective, right? Science tells the truth. Science searches for the truth.
Right.
And that means we need like objective measures that nobody can contest, right? Like everybody is seeing the same thing. Everybody is doing the same experiment, getting the same result, reliable results, and so on and so forth. So for a long time, in this kind of image of science, scientists or lay people or even philosophers have kind of, looked away from how actually science works on the ground. And then how do we actually get to that point of like replicating an experiment multiple times to get reliable results? And do all sciences work in that manner? And what does it mean for science to be objective anyways, right? Like,
right.
Is that like a, no first person perspective, or is it only has to be like third person perspective? But what if all of those third person people have agendas and kind of are misled in their perceptions and so on and so forth? So in contemporary philosophy of science, a lot of these conversations take place about, what does it mean to do like the science of the mind? How do we deal with subjectivity? Like on the one hand, there's a first person encounter experience, expressions of, perception or mental disorder, that kind of phenomena. How do we reconcile that with more third person observations and measures and so on and so forth?
Right.
So when we kind of look at the what I call like DSM psychiatry, there seems to be kind of lagging behind in the DSM's conceptualization of science from more contemporary recent work in philosophy of science. So one of the things that I try to do, for instance, in the context of, this interview is to say, listen, including first person experiences of mental disorders into the scientific knowledge generation process does not spoil the objectivity of science.
Mm-hmm.
So, and I will get to that. So with respect to the DSM, I think it's very important to kind of understand what the Diagnostic and Statistical Manual of Mental Disorders is and what it does, because sometimes people might be like, well, why do I keep talking about the DSM? Like, let's just not talk about the DSM anymore. Well, we talk a lot about the DSM because it's a document with a lot of power. So if you kind of, as you know, the first diagnostic manual was published, the DSM-1, in 1952. And since then, it's regularly revised and revisited. And the assumption is the more we understand mental disorders, the better we will be able to characterize and represent these disorders. And whatever we are discovering, learning through sciences about mental disorders has to be reflected into this manual, which is, I think, a fantastic project, right? Like, it's kind of forward-looking, open to, updating and changing things as things move.
Right.
But on the other hand, like, one thing that DSM is kind of tasks itself to do, the American Psychiatric Association, that is the creator of the DSM, you can see in the introduction, like starting with probably like, DSM-2, that like, what is this manual intending to do? So it's simultaneously used for multiple purposes. So it's like a Swiss Army knife. So clearly stated, researchers can consult or should consult this manual when they're conducting research on mental disorders. This has recently kind of changed. We can talk about that later. But basically what that means is that if I'm a clinical psychiatrist or psychologist, want to do an experiment, do a study on, depression, then I have to use the DSM's diagnosis of depression to kind of find research subjects and so on and so forth. Also used for clinical purposes to diagnose individuals, what they have. And that clinical diagnosis, again, for various policy reasons, becomes really, really important and powerful, because whether or not an individual's insurance will be covered, will cover their, mental health expenses, it's contingent upon them getting a DSM diagnosis. So then this kind of leaves clinicians in this like place too. Well, I don't really feel like you're full on depressed, but I know that you need help, and I'm going to try to find you like label here so that you can actually get what you need, right? So this becomes a process, and this is what I mean, like a very powerful document, right? It kind of, trickles in different platforms: research, clinic, insurance, disability needs accommodations, right? Like, when students require accommodations at the university for their mental health disabilities, they do need, not every professor asks for documentation, but they do need to register with the University Disability Services, and the University Disability Services actually requires a note from the doctor. Right. So in this sense, the DSM becomes what I have called this like cultural phenomenon, not just scientific or clinical phenomenon, but it becomes the kind of cultural, framework in which everybody thinks about mental disorders. Like, people Google their symptoms, people, just even kind of think about the folk conversations, right? Like, my students are like, oh, I'm so ADHD today. Like, that's
right.
Like, what, that's very interesting, I think, right? Oh, so like, okay, so ADHD diagnosis is this whole thing, but like being ADHD today is like, okay, that's definitely a kind of diagnostic concept trickling into the, folk language, the language that we use in conversations and so on. So that's kind of like the big entry, like, to DSM. And what I've been saying is this. So when we look at because DSM is this like tool that's used in research, clinic, various administrative, like insurance, whatever purposes, and it directly shapes an individual's life.
Yeah.
I mean, this is very important, right? Like diagnosis, a mental health experience, and the diagnosis, one might think would kind of, maybe determine the clinical, pathway in which this person receives help. But because of all these other influences, it ends up being a lot more pervasive and influential in their lives, right? And my earlier work, which I'm kind of going back right now as I'm working on my book, has looked, for instance, at how the very diagnosis of mental disorder influences the way one thinks about themselves.
Yeah. A la Hacking's looping.
Exactly. So Hacking was one of my PhD advisors, and I was heavily influenced by this notion of looping effects. And I kind of took that concept away from the philosophy of science and kind of started thinking more about it in the context of philosophy of mind and ethics. So that's very important. So one thing that I have been saying, listen, if individuals' lives, both the conceptual lives and actually physically literal lives, are being this much influenced by a diagnosis of mental disorder and in its treatment, why are not also we including them in the decision-making process that goes into creating something like the DSM? And what's really key here is, I think patients kind of provide two levels of information about experience of mental disorder. One is the raw, what philosophers call what it is likeness of having mental illness, right? What does it mean, like not being able to get out of bed in the morning, right? Like what does that mean, or how does that work for this individual? Or what does it, how does it feel to be hearing voices, right? So there's that experience. But the second layer of experience is like, what did they, how did their diagnosis affect themselves? Has this diagnostic framework been helpful to them? Did they actually receive what they need? So in that sense, like we kind of learn from patients, both as like experts of their experience, but also as people who have been in the mental health system and in society at large, who can kind of testify to all the unintended, perhaps unforeseen effects of a psychiatric diagnosis. And the way the DSM is created, I think, is at least like, speaking in the abstract, can accommodate this, because currently it only includes selected members of the American Psychiatric Association who are clinicians and researchers. So what I'm saying is, wait, let's give individuals with the experience of mental disorders a seat on the table, but not just a token seat so that we have like one token patient, something a lot more democratic, something a lot more kind of, process driven. And I have ideas about how to do that. And what kind of my more philosophical point about this is, and this is not going to violate psychiatry's or DSM-driven psychiatry's, striving for objectivity, because turns out, as feminist philosophers of science have talked about, objectivity of science increases if we have more processes of review, feedback, and what Helen Longino calls transformative criticism process integrated. So like people coming from a variety of different sciences or different perspectives can actually, at least in theory, hash out their ideas, challenge one another in writing and print over peer review. And then the ultimate goal is kind of a more objective, responsive account that, can be replicated and repeated in different contexts, like more objectivity. Yeah. So, and that's kind of the project, like including individuals' perspectives into the DSM project is not going to violate the goals for objectivity, which is what kind of the creators of the DSM had been resistant to, because prior to the creation of the latest version of the DSM-5, there was actually a conversation about whether and how to include individuals with experiences And then there was like just special issue, like some psychiatrists and clinicians like advocated, and like philosophers too, advocated for the inclusion of patients. But the DSM's official response, the APA task force's official response has been, well, no, well, we're trying to do science here. We were trying to be objective. We don't want to include that. So, and I'm kind of challenging, well, actually, you can still be scientific while also including this. And I have strategies to do that too, but that's another question.
Okay, so if I could respond to a couple of thoughts here. So going back to the beginning of what we were saying a moment ago, again, being the naive street level person, I look at science and I think epoche and agnosticism when practicing science. And so that's critical. And I'm not saying that in sort of to contest what's going on. It's just more that that's how I naively look at when people do science. They either put on their cultural relativism or their epoche, and then they go into the project without any sort of preloaded presuppositional kind of narratives built in. And then hearing that the APA is constituted of, when creating a DSM, of strictly clinicians or strictly say psychiatric background people, and not bringing in and I see this dichotomy from my perspective of science and the humanities. And so philosophy is, I guess for argument's sake, is in the humanities end of the spectrum, but why are there not philosophers of mind or philosophers of science like yourself at least being consulted? And I think that's the first step, or maybe a middle ground approach to what you're addressing here, is that if you don't want to include patients or people with experience, like as much more experience than any theory could work with, they can speak to the from the inside, first person, the ideographic perspective, which again to compare what you're talking about here, that seems the DSM and its architects, it's nomothetic, right? It's this big, massive monolith. And then you have these, what you're arguing for is the ideographic perspective to come in. Is there a possibility for synthesis of that? And I agree with you. I think it's essential. And as I mentioned earlier, and I'll turn it back to you, it seems like within the vast amount of people who are scholarly, who are academics, who are, say, in psychology or psychiatry or law or somewhere where they can be reliable reporters of phenomenal of their own experience, their inner experience, that should be a starting place too, to tap that resource of people who, obviously when you're dealing with mental health, there's potential for confabulation, there's potential for, things to skew their data that they're looking for. So would that be something that they would consider to maybe approach and say, can we have somebody on this, have a seat there that at least is a person who is a philosopher of science like yourself, / medicine / psychiatry, or again, somebody philosopher of mind who can try to be that intermediary to bring that voice in. And then if they loosen up on that, because, and then one more thing, and then I promise I'll bring it back to you. It seems to me like their conservative hesitancy to bring something not scientific in is kind of excluding an opportunity that, as you said a moment ago, it can be framed as credible, not necessarily empirical, but anecdotal information that can be refined, and you find consistencies and repeatabilities, which again, my naive impression of science is that you're looking for that. You're looking for patterns and regularities in nature, and we're nature, this is nature, and we could argue about the mind and consciousness and things like that, but to take a purely mechanistic view seems very unethical in that sense. I'll finish with that if that's not too polemical.
Yeah, no, that's very good. I think the question of so first of all, I absolutely agree with you that psychiatry, or the kind of community of like APA, whatever, it would be ideal if they had more, I guess, like established interactions with psychologists. I mean, that's also very interesting. Like, American Psychiatric Association and American Psychological Association don't get along very well, for instance, which I think is puzzling, right?
Yeah.
Or at least that's my perception of it. Like, I don't, I'm not in the inside, so I don't really know. I'm a philosopher. But I mean, one of the kind of exciting moments, like when we look at the history of cognitive science and, from the day it emerged, it started as an like kind of self-declared interdisciplinary form of inquiry that aims to understand the mind by using multiple perspectives. And they actually went beyond this kind of what I think is a false dichotomy, humanities versus the sciences. I think good science does need humanities, and good humanities does need science. I mean,
absolutely.
They have to complement each other. And in fact, I think in the best case of scenarios of both, they do complement each other. But that doesn't mean that individual disciplines like this, discoveries are not important, or that they should all be scientific or vice versa. No, we have to find a way in which to fill, because ultimately scientific knowledge or scientific way of perceiving the world is only one way of perceiving the world. You still get a lot out of, I don't know, reading Anna Karenina that you don't get from, science, right? Yeah. So in that sense, kind of, I think we should be pushing for that kind of complementation. And there's an example for that. Like when you, again, as I said, like when you look at the history of cognitive science, linguists, philosophers, psychologists, they all came together to talk about like the mind, to talk about like how does the mind work. Anthropology was actually a discipline, and people consulted anthropologists, like cross-cultural differences and so on. And anthropology is also a branch of science, but it's different from something like neuroscience or cognitive science, right? So I think, psychiatry, in its attempt to understand and address mental disorder, has focused a lot on biomedicine as its kind of model, or the side that it wants to be on. Because again, in the early days of psychiatry, psychiatry was kind of marginalized from biomedicine, and people did not want to be psychiatrists because they were like, oh, that's not real doctors. If you actually watch Mad Men, in one of the episodes, there's a character who talks about, I don't want to be a psychiatrist. That's not medicine. Like, and I actually kind of play that clip sometimes.
Right.
That was the perception. But that meant that, like, as psychiatry kind of tried to get itself more close and aligned with biomedicine, it moved away from perhaps like cognitive sciences, which I think provide a lot more kind of ground for understanding mental disorders, and also in terms of methodology, like cognitive science, even when you look at philosophy of psychology or cognitive science, there's a big debate about how to engage with first-person experience. There are philosophers like Owen Flanagan who promote what Flanagan calls the natural method, where the idea is to bring first-person perspectives with third-person perspectives and scientific perspectives to kind of have a complete picture of the mind. And if we kind of follow that, right, and in the context of psychiatry, then this assumption that that first-person perspective will spoil it is kind of ungrounded. Now, your suggestion about like, well, if they don't want the patients, how about like having people like you or others? I mean, I think that's a great idea. But at the same time, I don't know, like I kind of want to push more. I'm like, why is my witness testimony or whatever more important just because I have a PhD or I'm a researcher than, a person's like raw experience, right? But that might not have a lot of fans at this point, because like, I know that sometimes we have to move gradually, but I kind of want to like revolutionize things as opposed to like making small adjustments. But that's absolutely, I think, would be a great start.
Yeah, and I was kind of playing devil's advocate on their side, and their begrudgingness to seem unscientific. And again, you talk about the birthplace of psychiatry. You had people like Carl Jung and Freud who were throwing out these crazy ideas. Jung was into Gnosticism and quasi-spirituality and things like that, and weaving that into the psyche. And I love all of Jung's work. I'm not debasing it in any way. And Freud had his interesting thoughts, and they usually revolved around sex and things like that. But so maybe there's a knee-jerk, a century-long knee-jerk to that they want to be recognized as being credible scientists, and they can stand next to a theoretical physicist and say, so maybe there is their own psychiatric.
And I think you hit the nail in the head there. I think psychiatry's like attempt in the in the 70s to really distance themselves from Freudianism and psychoanalysis at large to becoming more scientific, with also the rise of the success of the biomedical model of disease in kind of the biomedical fields. That's, I think, one of the, like, in the kind of more history and philosophy of science tradition, I do think about that transition a lot. Like, oh, so they dropped Freud and Jung and psychoanalysis, but also at the same time kind of dropped a lot of useful concepts perhaps, and then kind of moved to this, like, the pendulum swung on the other kind of end.
Right.
And like now I think we are struggling to kind of bring those threads, like bring the best of everyone in a more meaningful kind of manner. But also I wanted to kind of circle back to your point about like clinicians or researchers or people who are both kind of have recognized degrees like MDs or PhDs and whatever in these areas, while also having themselves first-person experience of mental disorder.
Mm-hmm.
And I think that's a really interesting and good angle. And when we look at the history of psychiatry, the ways in which important changes happened in the DSM are driven by individuals who are recognized as legitimate experts, like they have MD degrees or PhDs, and have first-person experience. My biggest example is the removal of homosexuality from the disorder category in the DSM. It was thanks to the activism of a lot of psychiatrists themselves who were also, but then they kind of they did advocate, they did push, and there's actually like psychiatrist who gave a talk at the APA with a mask on, where he says Harry Anonymous, that was his kind of stage name, where he talked about how he was fired from multiple jobs as a psychiatrist because he was gay. And I think that speech was influential because like suddenly clinicians or psychiatrists were like, oh, okay, so he's one of us and yet experiencing this, right? So I think that's a good kind of line, but again, it's not sufficient because I think again, people just with raw experience, with experience-based expertise do also need kind of a seat on the table. But also I think there are conditions for that, right? Like I think having or being diagnosed with having a mental disorder is necessary, but not a sufficient condition for getting a seat at the table. Just like being a PhD or an MD does not automatically put you on the DSM task force, right? Like, yeah. And I think that needs to be determined, which hopefully I will have determined by the time that I finish my book.
Through your advocacy, yeah. Absolutely. And so to stop playing their devil's advocate, I completely agree that there needs to be something needs to break that ice and allow for, because I've been self-employed my whole life, so I've run several small businesses, and so I'm an opportunist. And I think anytime I see an opportunity, I take it. And what do they have to lose? They're not going to get egg on their face per se because they tried something, and that's what science does: is it experiments. It comes up with an idea like yours and works with it. And so Daniel Greenberg comes to mind when reading your publications as a good example of somebody who is a psychiatrist who had to go to a psychiatrist and interact with the psychiatrist. So I see that in a tiered processorial way. So you get the DSM authors to agree, or the lords of the DSM to agree to maybe bring a couple of qualified, again, advocates or professional witnesses to the first person, idiographic perspective, et cetera, and then warm them up to that if they can say, okay, then if there's consistency in patient reporting or patient first person anecdotes that they may give some ground, because like you said, with the breakthrough in homosexuality and they stopped deeming it to be a disease, and it's just how people are, it is, no different than any other human being. And that's ice breaking there. And that's getting things moved forward, I think, in terms of what really defines mental health and or lack of, or the absence of perfect mental health. Absolutely. Or the range or whatever.
And like there's a philosopher, actually, Anke Buter, published an article a couple of years ago where she says, well, actually incorporating kind of, this perspective into this whole machinery will actually might make DSM more trustworthy, because right now I think DSM is facing this kind of public trust crisis of some sort, where it's being criticized like by everyone basically. But at the same time, I mean, I don't want to kind of overstate my criticism. In a lot of ways, actually, it's been a very successful project and document, right? So like, we don't want to kind of throw away all of its like kind of the work that has been done significantly in the history, but perhaps it's kind of time to adjust the DSM's conception of science, especially in this kind of climate of culture of more public engaged ways of doing science. Like climate researchers incorporate the perspective of indigenous populations into their understanding of the climate change, right? I mean, that's very scientific, right? So, and there are different areas of science where there's this kind of turn to the, like, what we might call the publics, like the, people with the experience to understand better, make sense of like what's going on the ground. So, and I think that's very important. Also, I want to give it like a very important plug for philosophy here, because I'm a philosopher. I'm also an opportunist, I guess. Because I think philosophy can play a really important role here. Because, philosophy is good in its own right. It does not have to have an instrumental value. I'm going to say that. But also, I think in this context, it can have a very important instrumental kind of value, in the sense that philosophers of science, or philosophers of mind, or even, bioethicists are used to working with scientific and empirical data. I mean, a lot of philosophy of science happens with direct interaction with the scientists on the ground. A lot of, again, similarly, cognitive science or bioethics, it's all about things that happen on the ground, and philosophers come in, maybe help sort out the kind of mess, see things that individual branches may not be able to see, like in a kind of conceptual way. And I think that particular role, like in philosophers, again, right, like we have great philosophers who work on disabilities and kind of in bioethics, and philosophers of science and philosophers of mind. And I think we can kind of come to the table in a way that helps synthesize and create models to integrate that first person perspectives with more other ways of kind of approaching mental disorders. So in my book, I'm actually developing a concept of the self that I call the multitudinous self, inspired by Whitman's Song for Myself, where he declares that he contains multitudes. So that's the model of the self, and I kind of pitch it as a framework to integrate first person experience with third person kind of other scientific approaches of mental disorder, to kind of help us give a more complete picture of the individual encountering mental disorder, that will ultimately, again, clinically help these individuals and help them live better lives. So I've been kind of workshopping this model for a while in individual publications, and I've recently actually collaborated with some colleagues at UTSA and Utah University, who work with veteran populations and PTSD. And we looked at some of the data that they have on PTSD and veterans through the lens of my model. The statistician colleague in the group crunched some numbers, and we kind of came out with like, so this is what seems to be going on kind of model. So I'm hoping to kind of, do more of that kind of work, where I directly work with clinicians or psychologists. But I think that's the kind of special plug-in for philosophy. We can be super helpful if the DSM, lords, as you call them, decide to kind of, take into account what we think. And actually already there are quite a few philosophers who are at least in kind of close relationship with the people who are on the DSM task force and whatever. So I think they know that philosophers of psychiatry exist. So I will take that as a good start.
There may be penetration into that sphere.
Exactly.
And again, being the naive street level, person, I look at science and philosophy as that philosophy bookends science. So you start with philosophy, you go into science, and then you come back out and you sit around the table and you talk metaphysics or whatever it is that you're unpacking from your research that you've just done. So I tend to cringe when I see the spokespersons of science, the celebrity, pop sci guys who are like, well, they try to dismiss philosophy and say it's no longer necessary. We have reason and we have numbers. And so, I challenge anyone to pull qualitative information out of maths and equations. You've got to have a balance there. And I think the philosophers bring that dialogic, that what is it they bring? The love of wisdom, right? The love of processing, because if you don't process information properly, right, big questions, and they're more capable because God knows modal logic and things like that can be mind-numbing when they try to, you listen to philosophers really getting into a converse. So, and scientists may not want to even be bothered with it. They're like, here's what I found. And so, I almost see it as a very healthy symbiotic kind of relationship. But yeah, there are people who are resistant to that. And I think perhaps if I can intuit that some of the fear is that it may stray off into wild speculation, because philosophy incorporates speculative thinking, and they have to, but it's again done with rigor that is, far beyond what a lot of scientists are willing to deal with. So yeah,
I think like rigor there is the key. And again, when you look at history of science and philosophy, I mean, they were all my favorite example is people who ended up being big astronomers, important astronomers, offering groundbreaking, theories of the world and the sky or the heavens. Were also philosophers, but they were also making their money, making their living by reading people's tarots and doing astrology, right? Right. There is that, so actually one of the exciting things that I'm involved in right now, which has nothing to do with philosophy of psychiatry, but a lot to do with philosophy of science, is me and my colleague Chris Peckham are preparing to teach a course offered next fall at UTSA called Philosophy of Space Exploration, because we have so much enthusiasm now about space exploration. I mean, the new telescope that's now, I don't know, it's just it gives me a lot of joy to follow the James Webb telescope to see where it's at and what kind of data it's gathering and so on. And kind of one of the fundamental ideas that kind of gave rise to this collaboration is the fact that as an astrophysicist who read philosophy, he fully realizes that philosophical kind of questions and ethical questions have to be at the center of space science or space exploration. And similarly, I'm a philosopher, but I do think that we do really need to engage with what's happening in science, and that's good for philosophy. So I think these kinds of collaborations have a lot of promise, not just kind of in the kind of more practical clinical context, but also in the kind of in other contexts as well. And also, I think coming back to this, all of this is aiming to address, at least the work in philosophy of psychiatry aims to address, a crisis in mental health. I mean, we have been working so hard to make psychiatry scientific and kind of, engage with neuroscience and, develop kind of the, drug models or the brain disease models of mental illness and stuff. But guess what? There is still a huge crisis, and it's gotten worse after the pandemic, right? And people's lives are on the line. There are individuals with mental disorders who are really struggling, posing dangers to themselves and other people. And whatever we have does not work. Why not open the door for some kind of different ways of engaging with the topic of mental disorder? I think this is the perfect time for it.
Yeah. I think of an analogy when you talk about, just taking this, and this is not, I'm not stating this is what's going on, but using medical intervention, SSRIs and things like that to help people without, like you said, addressing the underlying issue as thoroughly as possible. And it is, there is integration there. There is the talk therapy and the medication. But yeah, I think people who think that there is some means to use pharmaceuticals to whatever degree beyond talk therapy is kind of like, I was thinking about somebody with a piece of glass in their foot and the doctor says, well, you'll never walk again. we're going to put antibiotics around, we're going to give you some aspirin for pain relief, but you're never going to walk again. And it's just a matter that the glass is in the foot. And yes, it makes sense that you'll never walk again. But if the doctor takes that one extra move and pulls the glass out, then you can heal and then you can start walking again. And I sort of use that as a really crude analogy for let's get the underlying issue that, yes, and again, pharmaceutical intervention is necessary, especially if people are in crisis mode and they do say, you know, the benzodiazepine family or something like that to bring them down a little bit, and then maybe put them on some regulatory things for their serotonin receptors. But beyond that, you know, where's the trauma, what's going on? And I know they do that. So I know that's, I'm not making a false issue here.
No, I mean, that's a very good point, Justin. I mean, again, like when you look at the policy and the administration, unfortunately, psychotherapy or talk therapy is not reimbursable for every health insurance, even though a lot of health insurances do reimburse like medications, right? I mean, like, I think this is what I mean by in practice, like it has like, there's a lot of like practical stuff that a person or a clinician might realize the patient actually could benefit from talk therapy as well as medication therapy and do them simultaneous. And I think a lot of clinicians do realize that, but their hands might also be tied because again, there are all these like constraints, right? Like, so like for a lot of people, the only way that they can kind of address their mental health issues is by going to a family physician who is not, trained in psychiatry, but can still kind of prescribe medications, and whether or not that person is getting the full even benefits of that medication without like extra kind of steps is kind of questionable. Right. And that's kind of what's making me worry. Like there are people hurting. And I think this is people hurting and not getting what they need is leading to, I don't know, a lot of kind of practices that are kind of questionable, or maybe they become different kinds of trauma or coping. And, they're drinking maybe a little too much to cope, or they're drinking, they're doing this a little too much to cope. And that's just kind of leading to like further issues and problems. And that's actually one of the goals of my work too. I kind of, I really want to think about and write about these topics, especially kind of mental disorder and its relationship with the concept of the self, also to offer kind of different kinds of conceptual resources for patients who are encountering or who are people who are encountering what they might call mental disorders. Because I think if we can connect those questions about cultivating the self, being happy, being well, into our experiences of our problems in our lives, whether that's mental disorders or physical disorders or, other kind of challenges of dealing with, I don't know, a sexist, work environment or whatever, right? Like whatever problems might be, I think if you kind of collaborate, if you join that project in our larger project of living a good life and being well and happy, that has a lot of benefits to us because unfortunately, psychiatry, or currently there's nothing that gives you a magic bullet to solve the mental disorder problem or that experience, right?
Yeah.
Like it's not an antibiotic that can dissolve the infection,
right?
Like, and then there are lots of other areas of medicine where the solution is really not clear, right? And especially because we do not have answers. We have more questions than answers. That's precisely why we have to integrate patients' perspectives to our understandings of mental disorders, because we have a lot more to discover and learn. There's no magic bullet. People have to do work on themselves. And that's, And people have to be supported in the right way so that they can actually, work on themselves. Like I'm not trying to attribute this, a whole responsibility to the individual with the experience of mental disorder. Like they do need proper accommodations and support and clinicians and therapy and medications or whatever they might need, right? But like it's ultimately a project where we are kind of struggling to be happy. Like it's like, it becomes a big kind of meaning of life kind of question, I think.
Oh, absolutely. Yeah, it immediately just boils out into this larger picture. And that's one of the things as a average Joe kind of person that I would love to understand more about, because what I see from my perspective, and I could be projecting things out myself, is that, you know, we live in an age of, as you mentioned a little while ago, we sort of feel good our way with alcohol or whatever it is. And I think there is a underlying kind of escapism that's going on with consumerism, in a sense that, you know, consumerism's okay, but then there's consumerism where you think the next object or trinket or whatever it is going to give you, and it does, it gives you this sort of temporary satisfaction. But are you ultimately chasing well-being? Are you ultimately chasing the sating of a desire to feel like your you know, your life is functioning normally? And so yeah, it gets big and it gets quick, and I think none of us are beyond that pull of that gravity of trying to make some meaning for ourselves and some self, like our own telos, like our own sense of purpose, right, within the system of life and our species and so forth. So yeah, excuse me, it gets big quick. So can you tell us, should we segue into talking about the self and the way we look at it? Like we got about a half an hour, 40 minutes. We can cover it all in that amount of time. But you mentioned, was it a multimodal? I'm sorry, what was it?
It's called
multitudinous.
Self.
Okay. Can you unpack that for us a little bit, and then we'll use that as our way of in getting into the subject itself.
Absolutely. Okay. So the concept of the self is super fascinating and interesting and complex and messy. But it's, I think, good kind of messy. It's largely messy because of history. Right. You know, the concept of the self played an essential central role in philosophy from, you know, day one. Right. Like we read Plato's dialogue, you know, in like, you know, Socrates' defense, where, you know, Socrates is told that, that he's the only person who knows himself. He has wisdom, and like know thyself, know yourself was like the big Delphic kind of motto. And that's kind of how, you know, we started thinking about the kind of the concept of the self, but also what does it mean to know yourself and so on. So these are very, very important kind of foundational questions, as you know, in Western philosophy, in which I'm trained. But also, like, you know, when you look at Buddhist philosophy and Buddhism, and there are a lot of kind of discussions and conversations about the concept of the self, and whether, you know, there's a thing called as like the self, like, does it exist? Does it not exist? Can we know it? If we know it, does that imply that we already kind of assume that it exists? Like, it's very complex.
Yeah.
And then, you know, of course, Descartes comes into the picture, starts thinking about like the soul and the science and, you know, the self, like, then, you know, the knowing the mind. And I think therefore I am, it just gets even more complicated. So this is why a lot of my mentors early on kind of told me, well, are you sure you really want to work on the self, or you really want to talk about the self in the context of mental disorder? It's messy. You're going to face a lot of objections. You know, metaphysicians will come after you, and, you know, they will chase you away or whatever. I mean, they didn't chase you away, but they were like, well, are you sure? And my response was, that's precisely why I want to work with this concept, because it's so resourceful, right? I mean, it has, and also I haven't even, you know, covered the history of the self in psychology. That's a whole other thing, right? Like, psychology is a scientific discipline, it's the science of the soul, and they have worked with self, the concept of the self, and all cognate concepts, you know, self-perception, self-concepts, and all that kind of stuff. So like there's also that tradition.
Right.
So what I'm trying to do is actually very modest, very minimal kind of pitch. I'm very upfront about how my, you know, the bread that I want to break has nothing to do with the metaphysical approaches to the self, or kind of, I'm not really super interested in kind of these, like, you know, those questions like, does self exist, and so on and so forth.
Okay.
My goal is to think about the concept of the self in very close approximation to the concepts of personal identity and personhood, you know, what it means to be a person, what it means to be a self, because I think personhood or personal identity do get at the intrinsic or essential properties that I want to attribute to the self, like being in relation with others, being a being in time or over time, in that, like, we were
Mhm.
adolescents and growing up and so on and so forth. We have this kind of conceptual like world like that we engage with through language or other forms of representation and so on and so forth. All of this is to say, my goal is to kind of to think about the concept of self in relation to real people. So there's this Oxford philosopher, Kathy Wilkes. She passed away years ago, but she's written this book in late 1990s called Real People, where kind of she pushes philosophers of mind to kind of start thinking about real people and their experiences, not just thought experiments. So I kind of took that to heart, especially in the context of mental disorders, because my interest in the topic really emerged from my observations of encounters with mental disorders that I was seeing around me. So my goal then is like to kind of think about the concept of the self as this fodder for getting at different dimensions of the complexity of persons who have real life experiences. But I'm packing it in a very scientifically digestible way, this complex mechanism with multiple dimensions, and I will talk about those dimensions, all with the goal of better understanding experience with mental disorder, but also developing a model to understand mental disorders that incorporates philosophers, scientists, clinicians, as well as individuals with mental disorders into the picture and study. So in some way, kind of if my negative project or the critical project has been the self is missing in the DSM, the kind of more constructive, positive project is like bringing the self in, or reclaiming the self and kind of putting that in the picture. So, and I can talk about the specific of this, like my multitudinous self model, if you'd like.
Yes, if you would. And because I did read, one of your publications, I think, was adjudicating the self-narrative, and you mentioned Lambston and his, if there were threads of narratives, and so did that influence it? But go ahead, and if you could explicate that. Yeah, if you could explain that, and then we'll go from there.
Absolutely. So I think that, like, just a kind of quick point about like narratives. Again, narrative is also a very complex concept. Yeah. But when I say narrative, I think about kind of the ways in the stories in which who we are represented by us or other people. So it can be like, my narratives about myself, how I'm a cat person or whatever, right? Yeah. And other people's like stories or narratives about me. So they're all kind of narratives. So in the picture, in my model of the self, there's no like narrative self dimension, but that's kind of an aspect of the conceptual dimension of the self. Okay. So basically, this is my model. So I think there are 5 dimensions. This is highly inspired by one of the kind of leaders of cognitive psychology, Ulrich Neisser, who has written about self-knowledge and different ways in which we can know ourselves, where he talked about like these almost like being 5 different selves. So my model is very much inspired by kind of a similar framework, but I kind of want to kind of think about these different dimensions, not as different selves, but different aspects of what makes up the self. Mm-hmm. So the first is the kind of, the bodily, the physical self. Again, these can be very loaded like notions, but by that I mean like our pure meat biology, brain, cells, hormones, like all of everything about our meat and the location of that meat in this like physical universe, right? Okay. So there's that dimension. There's the intersubjective or the social dimension, where kind of this very assumption that that we are social beings. I mean, we can't really exist literally without others. Somebody has to give birth to us. It's relational. Somebody has to feed us, like like that relational, and we do need other people, not just kind of for mere existence, but also for flourishing and leading a good life and so on. Like we're intrinsically social beings. Mm-hmm. And the third dimension is the kind of our temporal aspect. Okay. In that, like, we're always, I guess, like beings in time. I mean, continental philosophers have written a lot about this, but also in kind of more palatable terms, like in any given moment, I have memories and I have a vision for the future. And there are things that happen to me that change me as I, get older, and there are different life stages and so on and so forth. So that's what the kind of temporality gets in. And also, some experience like mental disorder might be worse or better over time and stuff like that. The fourth dimension is more like private. So this is, what again, we might call what it is likeness of being me.
Okay.
That kind of first person, like immediate, like raw kind of thing where, I can kind of experience privately.
Okay.
And then the fifth dimension is the conceptual self or conceptual dimension. And this is, I think, the most exciting dimension, which is what my work, what most of my work has been based on. So this is this idea that we represent ourselves to ourselves, and our representations of ourselves to ourselves is like informed by those different dimensions, right? Like I might conceptualize myself as a gregarious person, or as a short person, like whatever that other dimensions of the self, or as a kind of private person or whatever. But also these kind of self concepts are shaped by society and the culture and language and like reading and writing and stuff, like, so these kind of conceptual, so my other people's representations of me has an impact on me, or how I'm going to be perceived by others affect how I behave and whatever. So in that sense, the kind of conceptual dimension is what allows us to enter into a kind of a cultural world out there. So, and self-narratives, like the stories that we tell ourselves or the stories that other people tell us about us, inform our self-concepts.
Okay.
And so this is kind of like, what does that mean? So, I don't know, I'm a teenager growing up. My parents' narratives about me, about like, oh, she's very studious and hardworking, does affect how I conceptualize myself. Like, I don't have to actually just take that in and agree with that. Maybe, I don't know, like, because they were putting all that pressure, I developed the opposite self-concept or something like that, right? But I think the idea is these multiple narratives that we have about ourselves or other people have about us do end up influencing how we represent ourselves and how we develop our self-concepts. And that was what my kind of PhD work 10 years ago or 11 years ago, I don't know, 12 years ago, actually.
Okay. Talk about the temporal self, right?
Seriously, I'm revealing my age. But yeah, so that's kind of, what I've worked on. And then now kind of I'm writing a book, and that will, hopefully that model will be an illustrative, good model to think about mental disorders and how mental disorder narratives might influence the person for better or worse, and so on and so forth. So I don't know, it might be a little too much, but this is kind of the broad picture of what I'm after. And my goal is to kind of get scientists and clinicians listen to me.
Yeah, of course. Yeah. No, I think that's being multi-aspectual or multi system, or however, if I'm saying that wrong, is important, because we are dynamic. We are not two-dimensional. We're not dipole entities. We have lots of lines going out in how we behave and how we take things in. And so I would ask, it seems like each of those 5 elements can come on board as we mature. Like, so you have the Lacanian mirror thing going on, and maybe that's that first representative of or the first acknowledgement of the self. So would you say that they come online at different times of maturity and emotional intellectual maturity? Or
no, absolutely, that's a really great point. Like, for instance, like something like the intersubjective or the social dimension and the physical dimension are there from birth, right? Like that's kind of unique. And then other maybe dimensions develop and are fully realized as we get like older. Something like a kind of a conceptual self is when we can understand language, or when we can kind of talk about ourselves, and so on and so forth. So there is definitely that kind of these, I guess, like graded things. I don't want to say become online, because that's just kind of assuming that they're kind of, I don't know, they're like not real. But I mean, I think in some ways they're always there, and they're always developing and interacting with one another.
So maybe they express themselves.
Yeah, that's a much better, I think, like way of like thinking about it. I mean, I always kind of think about this like mechanism as this like self-regulating thing, right? Like how does it self-regulate? Like, so, sensing dangers from the environment and kind of adjusting, I don't know, the way like we dress, or the way we talk about ourselves, or whatever. Like we're constantly I mean, that's why I don't want to think about the selves as different selves. Like, I think there's a kind of robust unity underlying it. Again, like this is kind of metaphysics creeping in, but that's an important dimension. And that unity does not mean being static, but that unity is kind of how we self-regulate and kind of grow like this, like in a maybe more holistic manner, in consideration of like with the expression of these different dimensions. And Lumsden's article, so David Lumsden has written this beautiful article about how different kinds of narratives might influence a patient's like sense of self, and how they are responding to their mental disorders and so on. And one question that I raised there, which was also a question to myself, well, then how do we educate these like multiple narratives, right? Like, I mean, one of the reasons that, Walt Whitman's poem, like Song of Myself, was very, very appealing to me in naming my model of the self, because he says, yeah, I contain, yes, I contradict myself. I contain multitudes. And that's very revealing. Again, like I'm using a poetry to talk about philosophy and the self, which I think is also telling in terms of why we need all these, areas of inquiry. And that kind of stuff, very like notion of like, yes, I contradict myself, I think is very telling, right? We have multiple narratives about ourselves in a given time, where some of them blatantly contradict one another. Like, how is that even? How can I hold these two narratives
disparate
at the same time, right? And I think that's a big question. And then I think, how do we stabilize those narratives so that they become our kind of more integrated self-concepts is a kind of a mystery. But I think that's a very, very important question, because I think especially in the context of a like experience with mental disorder, there's a lot of questions about like, is this myself or is this my illness?
Yeah, it brings to mind the idea, which I don't know how controversial it is, but neo-dissociation that they talk about sometimes, like with hypnotherapy or with anesthesia, that there is this access us right now, access consciousness going on, or then when someone is in induction or is under anesthesia, that they can report afterwards, especially with anesthesia, that might have more weight to it, that they can, there's some recall there. So what we would call unconscious is actually, there's still an agent present that's experiencing. So would neo-dissociation, if that has validity, would that factor in as an element of that sort of mystery of that, how can I represent two states or two modes of presenting myself or expressing myself or being?
No, exactly. And I think that's why like neuroscience is so essentially important, right? In our understanding of the complexity of the brain, like how does it work that like, there's this seems to be like this kind of, this is even in dissociation, I'm still kind of experiencing myself as a subject of experience, except that like, this is kind of like, weird and whatever. And that's why I think we need, neuroscientists to come on board and tell us about like maybe the specifics as they learn. And I think there's really, really interesting work happening now by philosophers like Barry Smith and Claire Betty on the sense of smell and like kind of experience with smell, especially in light of one of the symptoms of COVID-19 being loss of smell. And it has been very disorienting to patients to lose their sense of smell. Almost more disorienting than like losing vision or hearing, because like smell is integrated into kind of so many of our experience with the world. And that has a lot to do with the areas of smell in our brain being close to like these other areas in the brain, and so on and so forth. And that's actually another kind of example of first-person science, or first-person experience being important in science, because at the Institute of Philosophy in London, they are actually bringing clinicians and patients with smell loss into the same group to talk about like, okay, so what is this experience like? What can we learn about smell from based on these experiences and stuff, which is, you know, a methodology that's been kind of frequently used in even cognitive science. But that's why psychiatry also has to use it. But I mean, all this is to say is, I think, like the complexity of the brain, or the complexity of like human mechanism, or this mechanism of the self, is very, very important to think about when we are thinking about these individual experiences like delusions or dissociations. A lot of, for instance, first-person reports of delusions is like, I don't feel myself as the center, or I feel like there's a void, like where there seems to be a detachment between an individual's perceptions and their experience as the subject perceiving those perceptions, if that makes sense.
Right.
Like really cool philosophers of psychiatry have written on this kind of separation between the I-ness of the experience and the my-ness of the experience.
Wow.
So it's fascinating and super, super interesting. And I'm really kind of excited about like, what does it teach to us about being a self, or, you know, about our brains, or, you know, how the mind works in general.
One question that comes to mind in your model, your 5-point model, is that in our technical age, with the rapidity and immediacy of information, almost the overwhelm of information, that, you know, we learn as social creatures through memetics and introjection and things like that. And so how is that? It's almost as though the switch has been, you know, from 3 or 4, like when we were sort of pre-technology, we had books, we had gatherings and social events, salons and things like that. And now, you know, if you really want to get into modernity with technology, you've got so much stuff coming at you with the internet and so forth. Do you think that that is going to change us psychically? Psychically, you know, that this is a new thing, a new thing from the environment coming in.
That's absolutely, yeah, that's a great point. I think environment or technology is definitely part of our evolutionary process, right? You know, and it has, unfortunately, I mean, I shouldn't say maybe unfortunately, it has targeted, I think, the experience of mental disorder or individuals with mental disorder, because they are more vulnerable, and we're all more vulnerable right now because of, you know, the pandemic going on and everything, that kind of artificial intelligence or all of this technology has entered in our lives a lot faster and with a lot less critical reflection than I think they should have. Meaning, so perhaps you've seen this, I published a paper on the use of these like therapy bots. I don't know if you know them, but they're these like chatbot therapists.
AI bots.
That's what they call the AI bots, that kind of provide cognitive behavior therapy or some sort like to its users. And I've been very critical of it in print. In the sense that it's based on a lot of assumptions that are false about how the mind works, or, you know, how people use technology, but also what exactly is cognitive behavior therapy, and what is the reason that it's, you know, cognitive behavior therapy is an effective method, and whether or not we can actually provide that by a bot. Like, there are all these very, very important questions that ought to be answered, both scientific and ethical questions ought to be answered, but unfortunately they have entered in our lives in a lot, you know, faster speed, and people just give it a try because, I don't know, like, you know, this particular chatbot costs like $5 or something. I'm like, okay, so I'll, you know, I'm really feeling depressed right now, like maybe that will help. And I think things like this, and also like there's no FDA control, I mean, there's no regulation
Yeah.
Because the technology is growing so fast, and like ethics and policy is not as fast, and so on and so forth. And I think that's entering into our lives. But I'm not a technology basher. I am actually fascinated by artificial intelligence and similar technologies and their applications in medicine at large. But I'm also, again, in the kind of traditional skeptical philosopher fashion. I would like us to think more and move, So, and I think definitely, though, to answer your question, that has entered our world. And I think they will, these technologies, these forms of representation will be trickling into our self-concepts and kind of the way that we experience ourselves. I mean, a lot of these chatbots kind of advertise themselves as being very helpful, especially to teenagers who they think don't want to talk to anyone, but like just kind of text. And I'm like, that's an interesting observation, but at the same time, like, I don't really know if I would be comfortable giving my teenager a bot to address their mental health concerns. I mean, that's can be also very dangerous and risky in different ways. But so that's kind of, I think, where I stand. Like, it is here. I mean, a lot of things are made possible thanks to that technology. I do not want to imagine a world without it. But at the same time, how the ways in which they might affect us, we have to think about that more, so that so that technology benefits us, does not harm us.
Right, absolutely. I think Thomas Metzinger is pretty much out in the open with talking about the need for moratoriums on the development of certain types of AI. And if quantum computing ever sorts itself out and comes online, and then, what are we unleashing? But I agree with him that, and I think he called for like a 50-year moratorium on, or some long period of time to cool ourselves off with. And so he was framing it in the sense of artificial consciousness, which I'm not one to question Thomas Metzinger, but I have a different interpretation of consciousness, right? So I got on the qualia path. I'm not an eliminativist or an illusionist. So like, I have this naive romantic thing that, we do have qualia, so anyway, but I totally agree with him that we need to be cautious, like you just said, and work on the ethics side of it rather than the commerce side of what can be exploited in that regard, and ultimately who gets exploited by that. It might start out all good and well, but we're finding the hiccups in social media right now, and some of the adverse effects of that, especially on younger people. And so let's take that as our cautionary tale and move forward with that. But I agree with you. Yeah, there's so much rich, but there's always a dichotomy, right? There's always the shadow and the light, and there's so much rich potential for that. But it is spooky that we think that turning a bot loose out as an app that's going, and it's also like mindfulness apps. There's mindfulness is very in vogue right now, has been for 50 years in the West, and it's gotten very popular. But there are issues coming up with people who are practicing mindfulness and not under the watchful eye of a trained person to watch and see what's happening, because there's an organization called Cheetah House, and they deal with people who get psychosis from what is essentially a dissociation process. And so there's a caveat to mindfulness as well. So, there's never because I think mindfulness is a great way for people to, like you said, sort of the folks, one step below folk psychology, like the general, like folk medicine for the mind is to go, and I do it. I meditate a couple hours a week, but it has to be done with caution. It has to be done with the right supervision and with the right training, So anyway.
No, absolutely. I mean, I think, and there are these different degrees, right? Like, there are some mindfulness apps that I see that, provide guided meditation and stuff like that. There's like that level. And that's, I think, like, okay, so this is a tool, like, that would work. And that's kind of very different from, promising that this bot is going to provide psychotherapy and like help, is like, and that's, I think, where like we need to, as you say, like look at like, okay, what is like, what is the cost benefit analysis here? And also, like, is it really delivering the promise that it's making? And I think being truthful is so important. I mean, truth is essential. And, you can't be over like kind of, I think this is where things that commercialize become concerning, right? Because commercial interests, people's interest in developing these apps and so on is not like really doing good for the people. I mean, maybe that is part of it, I don't know. But like there's a big financial incentive behind it. And I always tell my students, follow the money. If you want to understand something, follow the money, in the sense that, like, even in the history of psychiatry, you can see like when the medications became popular and the drug companies, I mean, just kind of like all these like other financial interests have a way of kind of clouding a lot of things. And I think that's what might be happening in this kind of big AI thing. And we do have, I think, this dimension as humans of like this intrinsic curiosity, but sometimes that means like jumping on the new wagon, like without action, right? There's this big thing, like it's like a fad,
Oh yeah.
Like there's a lot of that right now. So and I think that,
no, I use the term very metaphorically, but we are mimetic creatures. And I say that loosely and metaphorically, so don't take me too, we're not ants, but we have this sort of decentralized, sort of self-organizing societal flow to ourselves. And I love the term either murmuration or mimetics, or not mimetics. What was I just saying? It's not mimetics. What was it? Oh, a stigmergy. I'm sorry, stigmergy. I'm throwing the wrong words out. Yeah, stigmergy. And I really, again, loosely metaphorically like to think of us as stigmergic creatures, and that we do follow these trends, these social things, and we kind of flow with that. And and obviously there's things built into that by desire and the want for novelty and so forth. But I use that. And I also like to think of when we talk about AI and the future and how far are we going, Baudrillard's cautionary tale of the hyperreality. I don't get too much into postmodern philosophy. Some of it is interesting, but I love his simulacra, and then that leads to this kind of hyper reality. And are we heading in that direction when we we synthesize our normal interaction with reality with whether it's virtual reality or augmented reality? I think virtual reality is for gamers mostly, but augmented reality is going to have a very interesting future, I think.
It definitely will. And I think like that's kind of one of the reasons that I'm very excited about the kind of conceptual dimension of the self that I'm developing, because like one of its kind of, one of my goals is to better really integrate that, like what's changing with time and in time, and how that enters into our conceptual frameworks. I mean, psychoanalysis was also that kind of tool, like, when you think about it, right? Like look at all these movies made that centralize around the very notion of psychoanalysis, or the words that we use, right? Like, I must have, suppressed it, like, things like that, right? And it really kind of became a part of our language. It's different in the new generation. I think in younger generation, like we don't really find those kinds of concepts used a lot, and they are representative of like their own time. And I think that's a very, very interesting dimension. And all this, what stigmergies is that?
Yeah, that's stigmergy, which is it's like ants do it with pheromones, and birds and fish have much better reaction times than we do. So it's a sort of decentralized, self-organizing thought flow, I guess is a good word. Nothing spooky or weird about it. It's just that certain animals can act in unison, but without any kind of, like, we take dictation, we take instruction from people, or we learn to do patterns and behaviors. But I think stigmergy is just very spontaneous and autonomous. It doesn't have any kind of
very interesting
structure.
I have to look into this more, because that can be a really kind of instrumental way, like useful way of thinking about how the culture gets to us.
Yeah, I've got a good article I'll send. It's in the context of artificial intelligence. They're very interested in it. AI people are fascinating to follow. Like there's the thousand brain theory, where it's a bottom-up consensual process of mind, and so thousand brain and stigmergy as it relates to using rapid technology and so forth. So yeah, I'll send you that article.
That would be great. That would be awesome. Thank you.
Right. And again, I use it as a metaphor because we aren't colonial. I'd like to say we're not colonial creatures. We're tribal, we're social animals, but there's things to be learned, and like anything from nature, we can take away some ideas. And there's caveats attached to that type of stigmergy too, right? Because if we kind of all go into this sort of sinister side of that, we can lead ourselves into trouble. trying to think of, we're getting close to the time where we need to let you go, because I know you said you have another obligation coming up soon, and it is just after 30 minutes past the hour. So what do we wrap up with? Do you want to bring up some closing thoughts?
Well, maybe we can kind of talk a little bit about like medical humanities and like health humanities in general, because I think that kind of is a I don't want to say new, because it's not that new, but I think it's the more kind of recently it's becoming a lot more popular recently. This kind of interdisciplinary form of inquiry as like medical crises continue, whether it's like the pandemics or the mental disorder crises and kind of insufficiency of pure medical approaches and so on. There has been kind of turn to understanding the complexity of illness, disease, and health, not just in relation to sciences, but also incorporating humanities disciplines. So, and I find that kind of project very close to my heart, because in a lot of ways, the ways that I want to understand, I want to think about the self or mental disorder are heavily informed by, what we might call a health humanities kind of approach, in the sense that, I do want to read literature on, illness experience or first person experience, and draw to them as much as I'd like to read neuroscience or cognitive science or psychology and so on. And I think that's a kind of an opportunity, kind of going back to your opportunism, for us in the humanities and also in like various medical fields, to bring together different tools that we use to understand humanity and different dimensions of humanity in this kind of more interdisciplinary, multidisciplinary framework. And there's a lot of enthusiasm and interest coming from undergraduates as well, who are interested in going to medical fields. Like I have a lot of students who want to be doctors or, nurses and kind of clinicians in kind of different contexts, and like PAs and PTs and so on and so forth. And I kind of want to kind of instill this humanism in them before they even, dip their toes in like the medical world. Because I think, understanding illness requires understanding humans, and understanding humans requires both sciences and the humanities. So, and I think that's kind of I'm really, really excited about like the increase in the number of health humanities programs and interest in general on the kind of understanding of the human dimension of medicine. A lot of the problems that we have, either with the healthcare system or kind of the medical field in general, and various ethical problems that lie therein, I think stem from not a very well developed understanding of humanity and being a human. So I think kind of thinking about like this interdisciplinary collaborations in the direction of health humanities, at least, is very, very exciting to me these days, because I feel like we can reach to people who would otherwise not have read philosophy or other humanities disciplines, by way of getting them to take these courses at the undergraduate level, and so on and so forth.
And that's a good time, I think, before the things congeal or set, that they're flexible and open, and they go into the medical sciences that way. You bring to mind, I had lunch with a friend of mine about 2 weeks ago, on Saturday, and he's in his third year of residency for ophthalmology. And after showing me all his gross eyeball pictures, we were talking about some of what he's been going through as a sort of postgraduate doctor. And one of the things they have to do is go through an empathy exam. They have to be tested for empathy. And I'd always heard, and this is not being said in pejorative in any way, there a lot of people who enter into medicine and law are high functioning sociopaths, and it makes perfect sense that, and again, I don't mean the term sociopath in a pejorative sense. I'm all for it. It's like I have my moments of sociopathy too. But anyway, but that's what people are drawn into it, because you have to be extremely intelligent, you have to be functional, and you have to not fall apart when this chunk of hamburger comes into the emergency room that used to be a human, or a child has been burned and there's not much left. You've got to have your presence about you. And but he was telling me about the empathy test, and that reminds me of what you were just saying, that and that's on the back end, right? So putting it on the front end makes so much sense. Like he had already had his medical, he graduated, and so they're just screening for empathy, and then they can do remedial work or training work. And what's funny about sociopathy is that you can just learn mimicry of empathy, right? You can learn to understand what it is they're looking for in empathy. So it's almost a circuitous thing, but I love it, and I applaud that, because I think, when you do have to go tell somebody that their family member has died, you have to do it with some modicum of sincerity. And I know that doing it thousands of times, you get that tough skin, and you can do it, and you can do it sincerely, because I've interfaced with doctors in that regard. But like you said, getting them on the front end and preparing them for that, and getting, at least planting the seed and getting them to start to think about, because philosophy is so rich. I've come to it late in the game. I did it as my midlife project. Some people buy for Corvettes or whatever. Go. This was my.
That's the best kind of midlife.
Yeah, project. I never had a crisis. It was more an awakening. And I'm like, and I did it also preemptively so that I don't get dementia later than sooner, right? So if I boggle my mind with all, what's going on in philosophy, it'll keep those circuits firing. So, but beyond my selfish interests, I think there is just a depth of richness. And wouldn't it be great? You talk about psychiatry entering into the arts, the film, the vernacular of film and so forth. Wouldn't it be great to see some films being made, or some pop culture things being put out there that deal with some of the issues that we could have conversations about, right? Because when you hear about philosophy on TV, or it's so, there's not much going on. There's not much there, and I think it could be enriched without being too obscurantist or abstruse for people to deal with it. There's ways to present things very like you were saying with art. I call them the spa, like Socrates, Plato, and Aristotle. There's ways to draw out some real core concepts that we can all relate to in that. Or Neoplatonism is a synthesis of Gnostic Christianity and all these other great ideas, and that went on to inspire so many other things that's baked into a lot of our cultures, right? And that's one of the things that I find magic is to find it showing up in other places and presenting itself in more approachable ways, more palatable ways. So
absolutely. And then I think you're right, philosophy has different ways of reaching out to different kinds of people. I mean, people might be going to church or a mosque, and they can engage with Neoplatonists and read a lot more historical work and philosophy, and think about philosophy of religion. I mean, there are so many different ways in which I think philosophy can be, made more of an essential part of one's life. I was lucky in the sense that I grew up in Turkey, and at the time, the curriculum was so that in high school, you took a philosophy class, a logic class, a sociology class, and a psychology class. So there are 4 courses just in kind of, humanities, and that was always, that, I mean, I grew up, my first ever philosophy homework was on Sartre's, Being and Nothingness. I mean, when I think about it now, and I was 14, 15 years old, and that the impact that it had on me has been definitely palpable. And so I think even if I didn't end up being a philosopher, I was actually, I finished an economics degree in my undergraduate. I was not originally
okay.
Philosophy was my minor field. But I know for sure, even if I continued with economics, I would still be reading philosophy or thinking about philosophy, because I think, as you said, it's an intrinsically important project, and definitely helps you not have midlife crisis, have midlife projects instead.
Yeah. You turn a leaf and you develop a new renaissance for yourself. And you mentioned Sartre, and when we were talking about Hacking's looping effect, I immediately thought of Bad Faith, one of his other great ideas. And it's not the same, but I think of bad faith as something that you inherit and ultimately becomes part of your identity, right? And so there's so much to be learned from so many great thinkers over time that, if it could be. And so I will say, I guess, that the philosophy of aesthetics, which is kind of a minor house of aesthetics, that it's already present in the mainstream population, like the arts and music, is already prevalent. And so we do get that much, I guess. And that, to me, a lot of the German romantics and the idealists were all about, turn to music, turn to the arts, turn to creativity. That is the way to find, well-being and flourishing within yourself, is to, move into that. Yeah, like a subclinical Stendhal syndrome. You're just having this really.
Yeah, I mean, art therapy has becoming a very popular area in like in medical humanities and arts fields in general. And there are like some eating disorder clinics that encourage the kind of, you know, the individuals who attend those clinics like to turn to art and express themselves in like different artistic forms and so on. And I actually try to collect art that is kind of an expression of a, you know, struggling experience with mental disorder or something like that. Okay. You know, that's, I'm really interested in like those kinds of representations and the drawings and so on and so forth, because I think it does give a different kind of insight into the individual's experience that might, again, escape words, right?
Yeah.
There's actually a in a museum in Germany. I have not seen this myself, and maybe this would be a good way of to kind of highlight the value of patients' perspectives. There's a jacket, there's a straight jacket that's now part of the museum, and that there are all these like writings on it. Turns out the story is there was a woman, and the writing is in form of like stitches, but like she basically stitched words. She wasn't given a pen or pencil, and there was a kind of a deep desire to express herself, and that she ended up stitching this, you know, on a straight jacket, and that's so it's very powerful kind of visual to think about. And I always, whenever I'm having a bad day at work or don't feel like writing that day or whatever, I just think about that, and I'm like, okay, this is privilege, and this is very important, because like our words can become other, you know, can represent other people's silences and unable to express, and or not have the opportunity to express themselves, I guess. Like in that case, like she did not have a pen, so she had to kind of rely on stitching. But that's very important.
Absolutely. And for the audience, you can just Google schizophrenic artists and you get their perspective, and it gives you that, it does give you another facet of the first person insight, because some of the art is beautiful and some of it's dark. And when they're having the episodes, I've had friends with pretty strong schizophrenia before, and it's cyclical. Even with the meds, it's, you know, things go up and down, or they move in and out, and so the art that they create is fascinating. And there was a article in NPR like 20 something or more years ago, and it was a man who put together an audio representation of schizophrenia with the voices, it was ear opening, because it was not pleasant. It was very upsetting. So he gave you that representation audio. You were talking about the nose and the parts of the brain. Fascinating. It's probably in the archives. It's probably out there if you Google it. It's audio simulation of schizophrenia. I'm sure other people have done it too, but his work was fascinating. It just really impressed me. Yeah. So
thank you for telling me that. That sounds fascinating.
If I can dig it up, I'll send it to you. So I'll do that. And the stigma G. Yeah.
Sure. Too. So I know you're busy. So
no, I'm not that busy. I also have this article, there's a publication and a video on anthropogeny, and it's how we got this cortical capacity too. University of California's YouTube channel has a huge anthropogeny series, and it's soup to nuts. It's, you know, it's all over the place, including art, and, you know, very, very primitive art. And but the one thing they were talking about is how we got our cortical enlargement, and it's an interesting story if brains are your thing. So anyway, I can pass that on too, because that's kind of relevant. You know, it's like, that's a neat narrative too about how did we get into becoming self-reflective and self-authoring from instinctual, right? And that's something that fascinates me too. So anyway, but I know
part of me really wants to release like this kind of, I don't know, something to accompany my book that collects all of this stuff. Like, this is what I'm talking about, except I can't talk about all of it. Like, here's
just a reference library.
Exactly.
Yeah, absolutely. And I think you said you and a colleague are actually we're thinking about putting together a website, unrelated, but it was as a compendium of ideas, or there was some in one of your lectures.
So my colleague Ginger Hoffman started kind of this like mental illness alternatives or mental health alternatives.
Okay.
That kind of framework. So like, I mean, the goal is, I mean, this is like the other thing I think, like my work has been primarily in scientific psychiatry and like kind of medicine, but this does not mean that everybody wants to be or needs to be medicalized or whatever, right? I think like, you know, I want to make sure that there's room for a variety of selves. And, you know, there's actually a huge, you know, neurodiversity movement right now where people, you know, do not think that having mental disorder experience is a bad thing. There's mad pride movement, right? Like not everyone, you know, needs their like illnesses or whatever experiences to be addressed or changed and whatnot, right? And I'm really, really open and excited about that idea. So I think in that trend, there is a Ginger Hoffman has been working on developing this website where that contains, like, if you don't want to think about your mental disorder in these clinical medical terms, there's like this other path that you can kind of take. So maybe that's what you were referring to. So hopefully that will become more prominent as we kind of move on in that direction. But so I'm part of the I'm the executive committee of the Association for the Advancement of Philosophy and Psychiatry. It's app, like AAPP.
Okay.
And Ginger Hoffman is also one of the kind of executive members. And that group is actually a perfect example of their philosophers and psychiatrists and psychologists, clinicians.
Okay.
Everybody is interested in doing philosophy of psychiatry. And part of that doing philosophy of psychiatry also kind of might mean for some individual contributors to getting out of the kind of medical model or kind of more scientific approaches in kind of different ways. So I guess that's like the final plug-in.
Yeah, no, absolutely.
For resources and different kind of want to know what's going on in the field.
Yeah, because I believe you mentioned in one of your lectures that for schizophrenia, for instance, in more developing nations, is the better outcomes, I guess, because of cultural differences and just different behavioral patterns and stuff like that. So yeah, there's definitely alternatives. And it was hearingvoices.org or something was one of the websites?
Exactly. That's another website. That's again, all of these groups are kind of powers of individuals with experiences, right? Like they're coming together and talking to each other and sharing their experiences with each other and so on and so forth. So that's, I think, I mean, it's a really exciting time, I think, to be working on these things because there's like all this great stuff coming from this
constellation of good things. Yeah. It sounds like it, and you are a very important part of that. And that's again why I wanted to have a conversation with you, to have just yet one more element out there, one more video or whatever conversation that can bring this into awareness. So I'm so grateful to you for coming on to my humble little podcast or whatever it is that I do.
Much. Thanks for having me. I'm really thrilled to be here. It was a fantastic conversation.
It's mutual for you coming here as well and taking the time to have that conversation, because I've learned some things, especially from it's kind of a weird process when I research people. I really kind of, you get like really intense, like you're an investigating officer of something, you know, you're just like, you're doing your work. And it's, I love that because I learned so much. Like I've learned so much from your publications. And so I will have a link to your website down below. Speaking of that, you can be found on YouTube by searching your name. And again, your name will be just copy paste into the search and find more of her work. She has a number of good talks and lectures, and you can discover her that way as well. But your website will be linked below because your publications are in there. They're accessible. Somebody like me
try to keep my website apps, you know, up to date, and I do put preprints of my publications so that they're open.
So it's good stuff. It's good to, if this conversation whetted your curiosity, then continue on and we'll make sure you can get that. So all right, Dr. Tekin, thank you so much. And I would like to invite you back for when you do publish. You're publishing sort of something for the literature, but also in the future, you'll publish something that's available to the public, right? That what's the timeline?
Larger audience. So the first project is finish the academic book and then make it, you know, write a more publicly accessible trade book kind of version of that.
Okay. All right. When that comes out, I'll invite you back because I'm going to read the book, and then we'll have you back for that conversation too. And we didn't touch on cats here because.
Oh yes, can we plug in for cats quickly? Cats are great.
Give a shout out to the kitties. Who you have Chicken and Ozzy? Is that your kids?
Yeah,
your cats?
they're my babies. Yes.
Okay, and they're back home.
They're back home. They're in San Antonio. I'm at the University of Pittsburgh right now on a fellowship.
Oh, sorry for the mic.
Oh, that's okay. That's okay. Yeah.
I was just reaching for my cam because I've got my little producer right here. That's Spot, a little shelter cat.
Oh, so cute. Yeah, we need our kitties for creative energies. So
yeah, Yeah,
Yeah.
they're fun. They're like little people with their own little personalities. So,
Yeah,
but
yeah. As my friend and philosopher Megan calls, they are flossocats. So
yes, yes, and they do have some nonverbal lessons to teach about resting and relaxing, and time to play, and time to touch in with
ask
your
for what you need.
yeah, check in with you at 3 a.m, make sure everything's okay.
Exactly.
Yeah.
Exactly.
Are we okay?
Are we okay? Are we
Yeah.
still sleeping?
Yeah, I was sleeping, but now that you mention it, yeah. So,
Exactly.
anyway, well, on the note of our love for felines, I will again thank you so much for being here. I'm grateful to have had this opportunity to speak with you, and I definitely want to invite you back. So we'll get you in 2023 sometime, and when your book is out, and we'll have another discussion. Thank you. I'll say goodbye to you after I stop the recording, and thank you to everyone who has lasted this far into the conversation. YouTube audience, much appreciated. All right, take care. Bye-bye.
Bye.